For the next talk, would like to invite the chairpersons, Dr. Siddharth Gosavi, who's consultant physician diabetologist at Sai Gosavi Specialty Clinic and Namo Hospital, Bengaluru, and Dr. Sridhar K, who's the diabetologist and treasurer, KRSSDA. We welcome you on stage, doctors.
The next speaker is Dr. G. Vijaya Kumar, sir. He's a consultant physician and diabetologist at Diabetes Medicare Center, Chennai. And sir will be speaking on hypertension and dyslipidemia in CV continuum. Are we doing enough? Over to you, sir.
Dear chairpersons and the delegates, good afternoon to all of you. I thank Dr. LSM for giving this opportunity, and then it's a very prestigious conference as well. Now I'm going to speak about hypertension and dyslipidemia in the cardiovascular continuum. Are we doing enough? The answer for this is no, we are not doing enough. The reason is that if you look into the blood pressure, it is only about 50% of a population are good control, less than 140 over 90. And if you look at the triglycerides and LDL cholesterol, only 40% of them are under control. And of course, only 1/3 of a population are having HbA1c less than 7. And if you can see that, if you take all the comorbidities conditions together, it is going to be only 10% of our population are having a good control of all the three. Now, we have a huge problem now. We have about 10 crore people with diabetes and 13 crore pre-diabetes, and you can see that we have hypertension is about 31 crore people. Abdominal obesity and generalized obesity is very, very high in our country, and LDL is about 18 crore people, and and triglyceride is also very, very high in our people. And we have a different dyslipidemia. It's not usual dyslipidemia that we have. The high insulin resistance our people have because of the waist circumference and ectopic fat and visceral fat that we have. We got high triglyceride and low HDL thing. And then only 9% of Indian population are having HDLC more than 50 compared to 70% in blacks or whites. And serum triglycerides are also very high compared to what we see for whites and blacks. So you could see that the LDL pattern B is also greater in Indians compared to 3 times more commonly seen compared to other populations. All these things together can increase the cardiovascular disease. Unless we interfere here, I don't think we can get good results from the patients. Now, how does it happen? Actually, from risk factors such as hypertension, dyslipidemia, and diabetes, causing endothelial dysfunction, atherosclerosis, ischemia, myocardial infarction, remodeling of the ventricles, and then heart failure, and ultimately it goes to death. Usually, that's what happens usually. The issue is that intervening at any stage, you don't need, even if you are not intervening in the beginning, even at any stage of the life of these people, if you can intervene, it can modify the downstream risk from protecting from heart failure and death and other things actually. So it looks like that hypertension and LDL-driven atherogenesis are primary upstream drivers. So it's very, very essential to take care of both hypertension and LDL, and so that we can prevent the cardiovascular disease amongst diabetic people. Now, usually it is not additive. These two factors are not additive, but risk is multi-implicative. In the sense 1 + 1 is not 2, it's more than that. The reason why both are together, most of our patients will have together both by hypertension as well as dyslipidemia, because they have shared the same pathobiology with endothelial dysfunction, RAS activation, and inflammation and arterial stiffness both can happen together actually. So guidelines will increasingly emphasize integrated risk-based targets to our people. Now let us look into what are the targets that we need to have. You can see that 2024, that is the European Society sort of cardiology hypertension guidelines for classification and targets. If you could see that office BP categories, non-elevated if it is less than 120 over 70, and if it is elevated if it is between 120 to 140 and 70 to 90, and if it is more than 140, 90, you need to call them hypertension. Elevated, normal, non-elevated, elevated, and hypertension. So the two categories that we can have. And if you can see that the treatment target should be between 130 to 130, and also you should keep the blood pressure 85 and less. And of course, we have to keep it far less comparatively, depending on the risk factors, further risk factors that they have. The diagnosis of the BP is very, very important, because the confirmed diagnosis in the clinic or out of the office monitoring, such as home blood pressure monitoring or ABPM, to detect the white coat hypertension and masked hypertension both together. Both of them can be diagnosed by home blood pressure monitoring. But the only thing is we need to have validated devices, proper technique, and multiple readings have to be taken into consideration before naming somebody as hypertension. Of course, if we can have a telehealth and digital tools, the adherence and titration is easier for us so that they can get the best results that possible. If you look into the pharmacotherapy for hypertension, getting to goal is that start with a single pill, or most often in diabetics what we have is we'll have a combination therapy, and it's better to go for an FDC. It's better to go for a FDC because adherence is better. So, and the classes of drugs that we need to look into are the AC inhibitors, ARBs as a first choice, then calcium channel blockers, and later on thiazide and thiazide-like diuretics also can be taken into consideration. Of course, there will be a small category amongst our people to have resistant hypertension, and this can be mitigated to a great extent by adding spironolactone. And in spite of that, it doesn't come down, then we need to consider renal denervation in selected cases, that is very, very resistant hypertension. And also the role of SGLT inhibitors are also has to be taken into consideration. Resistant hypertension, they are very useful if you add a SGLT inhibitor. Of course, all of us know that lifestyle modification is the most important thing. Sodium restriction, DASH style diet, and weight loss. These are the three things. Physical activity should have both aerobic and resistance exercises, limit alcohol and cessation of smoking. Very important. And potassium intake and sleep optimization. This is what we don't really look into, that sleep optimization. Of late, the screen timing is so much nowadays for people. I think it's getting disturbed sleep has been very common. They're going to bed very late and getting up also very late. Now, what is the targets that we need to have is that as low as better, lower is better. We can have that high-risk population to have LDL less than 70, moderate risk less than 100, and often if you got a high risk, very high risk, then you have to go for less than 55, and selected extreme risk population, then you have to go for less than 40. This is the usual targets that we have. And also include in your panel of testing the ApoB and lipoprotein little a as risk modifiers, and you can use them because so that we can have expand use of combination therapy to address these factors as well. Now, as far as the LDL lowering therapy is a high intensity statin to maximum tolerated dose. If after maximum tolerated dose of statin is given, and if you still have a problem, then you can go for add-on ezetimibe. That's a very good combination. Statin with ezetimibe is very good in reducing the LDL very nicely. Still, if you want, you can have PCSK9 protein inhibitors or your inclisiran. These are all injectables and very expensive. Alternatively, suppose somebody has got a statin intolerance, then we can consider bempedoic acid, which is available in our market now. Don't forget the typical Indian phenotype of dyslipidemia with a high triglyceride, not very high, like more than 400, 500. Very often we see triglycerides, in spite of having a good control of diabetes, we have 200, 250s like that, with a low HDL. And we need to address these two because this is the only option that we have to reduce the residual risk after statin therapy. And there are some very good evidences to say that it is possible to take care of reducing the residual risk, say like, the Accord lipid arm has clearly shown that adding fenofibrate has given further reduction in CAD amongst people on already on statin, and if the triglyceride is more than 205 and HDL is less than 35, then you can see that the benefit is all been addressed too. So earlier treatment to reduce lifetime LDL exposure is very important as soon as possible. Don't wait for that. And lower LDL goals by risk star. Okay, and then lipoprotein little ApoB testing also is very useful. Integrate lifestyle plus pharmacological therapy across population is a very essential thing. Now, simultaneously, BP and LDL control shifts the patients. No, both if you address nicely, it can shift the patients to lower absolute risk strata. And then every 10 millimeters of reduction in systolic blood pressure and 40 reduction in LDL drop would yield additive MACE benefits as well. In fact, even UKVT has shown that hypertension has given a very good indicator for reduction in CVD amongst people. And use team-based care plus, single pill combinations or FDC is what we call, plus combination of lipid-lowering drugs to close the gaps. A diagnosis, what we need to do is that a diagnosis, assess global risk, measure BP properly, fasting, non-fasting lipids, and other, you have to take in, and then start both statin and as well as antihypertensive therapy, and look into every 4 to 6 weeks we need to monitor, and also include, very important, to every 4 to 6 weeks we need to check whether we have reached the target or not. Otherwise, what happens is that earlier treatment, reduction in lifetime of LDL exposure is not going to be there. And of course, special populations, we need to have different considerations. Elderly and frail people, the systolic blood pressure target be a bit relaxed, not to, as much as possible, taking into consideration the orthostatic hypotension that people very often can have. CKD, diabetes, stroke, aim for stringent LDL goals, and ROS blockade often preferred. Statin intolerance, we have bempedoic acid and also SDMB which are available. And in spite of that, we have no results. Then we can go for PCSK9 inhibitors and inclisiran as well. Now, how do you monitor? Again, further is that also check the basic metabolic panel, BMP's basic metabolic panel. Also look into electrolytes, definitely, especially when you are on SGLT inhibitors. Especially when somebody has got an ACE inhibitors or ARBs, and also diuretics if they have. So hyponatremia is common. And then in ACE inhibitors, ARBs, hyperkalemia is a possibility. So monitor for orthostasis in elderly people. And if you have, if you have the intolerance to statin, you have to check for CK, and as well as LFT is also very important, and see the other ends. And of course, registry EMR prompts for timely intensification and follow-up has found to be effective in reaching the targets as soon as possible. Now to the question that are we doing enough, the quick test is that we need to do, as I said, that we need to diagnose it properly with proper instruments. Also for home blood pressure monitoring, and ABPM are very useful ones. And then also SPCs that you need to give, and then also aggressive treatment of statin is also important. We have to have a checklist, all these things. 3 things we need to have so that we can do the best for them. In short, we can see that it's a cardiovascular continuum. You have risk factors, endothelial dysfunction, atherosclerosis, ischemia and heart failure. And then you can see that if you have a high blood pressure and high LDL, it's not one trouble, it's a double trouble. 1 + 1 is not 2, and it is more than that. Appropriate pharmacotherapy and LDL lowering therapy should be addressed extensively. Before that, lifestyle modification, especially weight reduction and also cessation of smoking are very, very important. And then compared to baseline, you need to bring down the blood pressure to less than 130/80. And also, according to the risk factors, at least to LDL less than 70 is a good factor that we can think about. Have a checklist and all the drugs that can be used that we have already discussed. And most important thing is a follow-up. That is a very, very important thing. So let me conclude to say that the take-home messages are treat blood pressure and LDL cholesterol simultaneously for optimal cardiovascular risk reduction. Aggressively titrate medications every 4 to 6 weeks to reach the target goals. Employ a multidisciplinary team approach to close care gaps and ensure comprehensive management. Emphasize lifestyle modification alongside pharmacotherapy for sustained benefits. An integrated, aggressive, and team-based care saves lives. And also don't forget the typical Indian lipid phenotype. Thank you for your patient hearing.
Thank you, Dr. Vijaya Kumar. I think it was a wonderful narration on the dyslipidemia management as well. Sir, I just have one question before asking to the audience. Repatha, the injectable format. You have any experience on that?
I don't have any experience.
You don't have any experience.
Even PCSK also increases nothing. I don't have any experience.
Okay.
It's more of whatever I got from the textbooks I'm telling.
Okay.
We use Repatha and inclisiran. You have to remember that Repatha acts faster than inclisiran. Inclisiran blocks the synthesis. Repatha blocks the PCSK9. So when we use these in patients with acute coronary syndrome to slash down LDL, for the first injection, Repatha would be preferable and then inclisiran, because inclisiran takes time. Earlier you lower LDL, better are the results. And the good message is, arrest of atherosclerosis starts when your LDL is less than 70. That's why everybody says, like him also, keep your LDL less than 70 even for primary prevention. Regression of atherosclerosis starts when LDL is slashed down to less than 50. That's why many people keep it at 30s and 40s even for primary prevention.
And we can achieve with a lower doses of statins. And as a primary care physicians and diabetologists, we don't need to go for 40s and 80s of rosuvastatin like what cardiologists, because we see them before an event and they see after an event. So there is a difference. I think it's possible. Actually, we are able to get 10 to 20 milligrams of statin. We are able to get the good results actually.
So just one question, sir. If hypertension is well controlled, and if the patient doesn't have dyslipidemia, but has high inflammatory markers such as hsCRP or interleukin-6, should a decision on statin be taken based on inflammatory markers also?
I think a low dose of statin is also a very good idea, because inflammation does come down with statin therapy. And in these patients, I think we need to look into HDL and as well as the triglyceride content. We look only in the LDL, but we have to look into also these two factors, especially for Indian patients.
Yes. Thank you, sir.
For 40 to 75, irrespective of the baseline LDL, statin is indicated for this particular age group, 40 to 75.
Sir, one question. 1 minute. To Professor Dr. P.C. Manoria, sir. Sir, to you, sir. Regarding the lipid-lowering agent, PCSK9 or inclisiran in the management of acute coronary syndrome, sir.
I said, this monoclonal antibodies, they reduce LDL. Onset of action is much faster than inclisiran. So first injection may be monoclonal antibody and then inclisiran. Inclisiran is good for compliance, because once in 6 months, after 0 and 3 months. So that is the, inclisiran doesn't
No, no,
act
which
fast.
one is
It
better?
goes
Which one do you think is better, sir? This PCSK inhibitors
No,
or
no,
inclisiran?
both are very good, but in ACS we want to lower down LDL very fast.
And,
So-
and then inclisiran, I think it will reduce the even PCKC proteins itself actually. Do you think that's better
After
than
first
that?
injection, you can use inclisiran because every 6 months, there is monoclonal antibody every 15 days or every 4th week. That is the difference.
Thank you.
Thank you, Doctor.
Thank you so much, doctors. We would request the speaker and chairpersons to move towards the selfie area, which is outside the hall.